Hello, my name is Dr. Alan Valadie. My team and I have put this presentation together to provide and summarize some information that we feel is important to know prior to upcoming surgery. The plan for this presentation is to review some pertinent anatomy about the knee and to discuss surgical treatment including partial knee and total knee. We're also going to review some information about anatomy of the hip, discuss surgery on the hip with total hip surgery. We're going to discuss issues that are important to be aware of in preparing for surgery, how we're going to manage the pain after surgery. We'll discuss therapy a bit, go over some frequently asked questions, and then talk about potential risks and complications of surgery. Hopefully we can help you understand why and how the surgery is performed and help you understand the typical operating room course. We'll also discuss a typical recovery and discuss possible complications and how you and your surgical team can help minimize the risk of these complications. To briefly discuss pertinent knee anatomy, the knee is made of 3 different bones: the femur bone or the thigh bone, the tibia bone or the shin bone, and the patella or the kneecap. The cartilage is the material which is a smooth tissue that cushions the ends of the bones and allows them to move freely and with low friction. With arthritis, we see inflammation and the destruction of the cartilage tissue. As you see in the x-ray on the slide, the knee on your right shows a nice space between the bones, which is the cartilage. The knee on the left is an arthritic knee. There's no space, which means there's no cartilage. It's completely worn down in that knee. There's different types of arthritis, including osteoarthritis, which is the most common. That's simple wear and tear arthritis. Rheumatoid arthritis is an inflammatory arthritic condition that can affect the whole body, and we sometimes see post-traumatic arthritis after an injury to a joint. The knee is divided up into 3 compartments: the medial or the inside part, the lateral or the outer part of the knee, and the patellofemoral or underneath the kneecap. Arthritis sometimes involves just one compartment, and in that instance we can consider a partial knee as a solution. When arthritis involves more than one of the compartments, a total knee is the proper procedure. A partial knee replacement is a procedure in which we just resurface one compartment or one area of the knee. We prepare the bone and then position metal implants on the end of the femur bone and the upper end of the tibia bone, and we place a spacer or a high-density polyethylene part in between the 2 metal pieces. In a total knee replacement, we resurface the entire knee joint. We resurface the end of the femur bone with a metal cap. We resurface the upper end of the tibia bone with a metal cap and place a polyethylene piece in between the 2 to act as a new cushion. We also typically resurface the underside of the kneecap with a plastic piece. Moving on to the hip joint is a ball and socket joint. The ball is part of the femur and the socket is part of the pelvis. Cartilage is also in the hip and functions as a smooth surface to cushion the hip and allow smooth range of motion. In an arthritic hip, the cartilage is damaged and worn. As you see in the x-ray, there's no space between the ball and socket, indicating complete loss of the cartilage that typically cushions the joint. The surgical treatment for end-stage arthritis of a hip is a hip replacement. In a hip replacement, a new ball and socket are inserted. The socket is inserted up into the pelvis. That's a titanium socket with a plastic or polyethylene bushing or liner. The ball is attached to the femur with a titanium piece that we wedge down into the upper part of the femur bone. The ball is typically made of ceramic material, so the articulation is ceramic on polyethylene. Here's some information regarding logistics and contact information for the 2 facilities where I perform surgery. If I feel the surgery is best done at the hospital, we'll do that over at Blake Medical Center. If we feel an outpatient procedure is best for you, we'll do that at our surgical center on State Road 64. Again, you can read through this at your leisure and contact information is provided. Here's some other details to remember prior to surgery. Remember not to eat anything after midnight. We encourage you to drink clear liquids up to 3 hours before the surgery to stay well hydrated. There are some medications that you'll need to stop preoperatively, mainly things that will thin your blood out, such as aspirin, Motrin, etc. We also like you to stop some biologic agents that some patients may be taking for rheumatoid arthritis. It is okay to continue Tylenol and Celebrex. Here is some information regarding various ice machines that can be available to you after the surgery. It's important to have a walker and a cane to assist you while you're recovering from the surgery. The anesthesiologist will meet you the day of surgery and discuss the best anesthesia for you. Our preference is a spinal anesthetic with sedation. In some cases, general anesthesia is the more appropriate choice. Our typical skin closure involves dissolvable sutures under the skin and glue on the outside of the skin. We then place a waterproof dressing that stays in place for 1 week. It's okay to shower in this dressing. Very occasionally, we might use what we call a wound vac negative pressure system that stays in place for 1 week. The dressing is typically left in place for 1 week and then peels off like a Band-Aid. If there's no drainage, you can leave the incision open to air and start showering right away. On the day of surgery, after preparation in the preoperative area, you'll be transported to the operating room. Total time in the operating room will be between 1 and 2 hours for the positioning, the procedure, and the closure. You'll then be taken to the recovery room. At the surgery center, you'll be discharged home from the recovery room. If your surgery is done in the hospital, you'll be taken to the orthopedic floor. Discharge requirements after hip and knee replacement include clearance from physical therapy to make sure that you understand gait training and the use of assistive devices. You have to be medically stable with stable vital signs. From a pain management perspective, medications will be sent to the pharmacy either prior to the procedure or at least just prior to discharge. This is our typical pain protocol for after surgery. There's some exceptions to the rule, but generally speaking, we recommend Tylenol regularly scheduled for the first week or so. We also recommend regularly scheduled anti-inflammatories such as Celebrex for the first month. We then recommend a mild pain pill such as Tramadol to use as needed, and oxycodone as a stronger pain medication only to be used as needed. Here's some additional medications. It's very important to be on a blood thinner for approximately 1 month after the surgery. Typically, we use baby aspirin twice a day. Some patients will require stronger blood thinners such as Eliquis or Xarelto. In addition, we recommend a stool softener such as Senna to try to minimize risk of constipation. We can use Zofran as needed for nausea. Very occasionally, we'll place patients on an extra week of antibiotics depending on their risk for infection. Physical therapy is an important part of the surgical process. For patients having surgery at the surgery center, we'll usually recommend 1 preoperative physical therapy visit. Outpatient therapy after the surgery generally starts 2 to 3 days after the procedure, proceeds for 4 to 6 weeks. We also recommend home exercises when you're not visiting a therapist directly. Regarding follow-up visits after surgery, the first visit in the office is generally 2 weeks post-operatively for a wound check and x-rays. We then like to have a revisit 6 weeks post-operatively and then 3 months if needed. Our goal is to get you back to activities as quickly as possible. Here's a reasonable schedule. Returning to work, such as a light-duty job, can be 2 to 4 weeks after surgery. More heavy-duty labor can be 6 to 8 weeks. Driving is typically 2 to 4 weeks. If we operate on the right knee or hip, it can take a little bit longer, as opposed to the left side, which can just be within 2 weeks. Flying is preferably held for 3 to 4 weeks after surgery. From a return to activities perspective, usually after about 6 weeks, most people are getting into light exercise and reasonable activities. More aggressive activities such as tennis, downhill skiing, etc. can take up to 3 months. Patients that have both knees or hips that need surgery can have this done within 6 to 12 weeks at the earliest. There are potential risks and complications to any surgery. We try to minimize these risks, but to review them, infection and blood clots are the things that we worry a lot about. Thankfully, these are both less than 1% with appropriate precautions. True hematomas are uncommon, but some degree of bruising and swelling is actually quite common. Loosening or failure of the implant can occur over the long term. However, success rates of hips and knees are in the 85 to 90% range 20 years after surgery, so it's relatively rare. Residual pain or stiffness is relatively uncommon, but can occur up to about 5% of patients. Fractures are relatively rare, less than 1%. Nerve injuries are relatively rare. Blood loss can be expected to some degree after surgery, but it's quite rare that we see that to the point where we need to consider any surgery or a transfusion. Clicking is not very common in hips, but is actually relatively common in knees. That doesn't mean that there's a problem, but can take some adjusting to. Leg length discrepancies are relatively rare, but are possible after hip replacement surgery. They're also possible after knee replacement surgery, but it's more of just a perception of the leg length as a change from the preoperative status. Insomnia and sleep disturbance is relatively common after surgery, but typically resolves over 4 to 6 weeks. There are some symptoms after surgery that might be worrisome but are actually quite common. Swelling throughout the leg after a hip or a knee replacement is common, as well as some bruising. Sometimes there's some minor warmth and even some minor incisional redness. Low-grade temperatures below 101.5 are relatively common. We do want to hear from you if you have significant calf pain, swelling, or redness, fevers above 101.5, significant drainage from the incision, pain that is uncontrolled with medications, or any increasing redness. Here's a checklist you can use to make sure we have everything in place prior to the surgery. My goal is for you to have a good surgical experience and a fantastic outcome following the surgery. If you go through this presentation and there are still any questions, I am more than happy to sit down at any point prior to the surgery to make sure all your questions are answered and we know what to expect leading up to surgery.